To cut the endotracheal tube to length, remove the connector. Note that the connection to the tube may be tight, and then cut the tube diagonally to make it easier to reinsert the connector. Replace the endotracheal tube connector. The fitting should be tight so that the connector does not inadvertently separate during insertion or use. Ensure that the connector and tube are properly aligned so that kinking of the tube is avoided. Connectors are made to fit a specific size tube. They cannot be interchanged among tubes of different sizes. When inserting the stylet, it is essential that the tip does not protrude from the end or side hole of the endotracheal tube to avoid trauma to the tissues. The stylet is secured so that it cannot advance further into the tube during intubation. Select a blade. A 0 is typical for preterm babies and a 1 for term newborns. Attach it to the handle by holding the blade and handle parallel. Place the hook of the blade over the bar of the handle and pull downward along the plane of the handle. Turn the light on by clicking the blade into the open position to assure that the batteries and light are working. Check to see the bulb is screwed in tightly. First, stabilize the baby's head with your right hand. Free flow oxygen should be delivered throughout the procedure. Second, slide the laryngoscope blade over the right side of the tongue, pushing the tongue to the left side of the mouth, and advance the blade until the tip lies in the vallecula, just beyond the base of the tongue, or place the tip under the epiglottis and lift the epiglottis upward to expose the glottis. Third, lift the blade slightly, thus lifting the tongue out of the way to expose the pharyngeal area. When lifting the blade, raise the entire blade by pulling up in the direction the handle is pointing. Do not elevate the tip of the blade by using a rocking motion and pulling the handle toward you. Poor visualization of the glottis may also be caused by not elevating the tongue high enough to bring the glottis into view. If these structures are not immediately visible, quickly adjust the blade until the structures come into view. Applying downward pressure to the cricoid, the cartilage that covers the larynx, may help bring the glottis into view. The pressure may be applied with your own little finger or by an assistant. Suctioning of secretions may help to improve your view. The most common reason for unsuccessful intubation attempts is never adequately visualizing the glottis. If the laryngoscope is not inserted far enough, the view will consist mostly of the base of the tongue. To correct this, advance the laryngoscope down the tongue until the airway appears. If the laryngoscope is inserted too far, the view will consist of the esophagus. To correct this, slowly slide the laryngoscope out until the airway comes into view. If the laryngoscope is inserted off to one side, the view will consist of the glottis off the side of the blade. To correct this, gently move the blade back to the midline and advance or pull back the laryngoscope, depending on the landmark seen. Holding the tube in your right hand, introduce it into the right side of the baby's mouth, with the curve of the tube lying in the horizontal plane. This will prevent the tube from blocking your view of the glottis. Keep the glottis in view, and when the vocal cords are apart, insert the tip of the endotracheal tube until the vocal cord guide is at the level of the cords. Stabilize the tube with one hand and remove the laryngoscope with the other. With the right hand held against the face, hold the tube firmly at the lips and/or use a finger to hold the tube against the baby's hard palate. Use your left hand to carefully remove the laryngoscope without displacing the tube. Attach a ventilation bag or a key-piece resuscitator to the tube, take steps to be certain the tube is in the trachea, and resume positive pressure ventilation with 100% oxygen. Breath sounds should be audible over both lung fields, but decreased or absent over the stomach.
Don't hear it on the left. 52.
Colorimetric CO2 detectors change from purple to yellow in the presence of carbon dioxide. If the tube is in the trachea and there is adequate cardiac output, the color change should occur within 5 breaths.